All right, we will go ahead and get started. Good evening, everyone. Thank you all for joining us tonight. My name is Caitlin Gaskin, and we are here with Dr. Nolan for the Signs, Risk, and Treatments of a Stroke webinar. A Georgia native, Dr. Nolan is a board-certified neurologist with Tanner Multiple Sclerosis Center and Tanner Neurology in Villa Rica, Georgia. She earned her medical degree from the Georgia campus of Philadelphia College of Osteopathic Medicine in Suwanee, Georgia, and her master's in public health from Emory University. She completed her neurology residency at Grandview Medical Center in Dayton, Ohio. Dr. Nolan has completed a fellowship focused in MS, neuroimmunology, and spasticity management at Riverside Methodist Hospital in Columbus, Ohio. Dr. Nolan, I will hand it over to you, and you can start whenever you're ready.
All right, perfect. Thanks so much, Caitlin. Good evening, everyone. Thank you so much for joining us this evening to talk about stroke. I'm a huge proponent of making sure that I'm able to provide comprehensive care for my patients, as well as ensuring that others that are involved in their care also understand different things from my perspective. So I'm really excited to be able to help educate you guys on stroke, which is a huge part of neurology. And unfortunately, we see it more than we want to. So today we'll be going over stroke, the signs of stroke, risk, as well as different various treatments that we have for stroke. There we go. All right. So a couple objectives of things that we'll be discussing today. Again, there are different types of strokes. So we'll be going over those, and as well as talking about how we diagnose and treat strokes. I want to spend a little time going over how we recognize strokes and how we act fast. So this is an acronym that we'll learn a little bit more about later. And then how can we reduce risk factors? There are several different types of risk factors, and we'll go over those as well. So let's jump right into it. What is a stroke? So with a stroke, we all have blood vessels that carry blood to the brain from the heart. These blood vessels are what we call arteries. When I was first learning about the body, I remembered that an artery goes away from the heart. So I associate the A in artery with away. What these blood vessels do, again, is they carry oxygen and blood and nutrients to the brain. The brain needs a constant supply of this in order to function. Each artery also supplies blood to a specific area of the brain. And if a stroke happens in one of these arteries, then that part of the brain may not function properly. So if it doesn't get the blood that it needs, it can die. And when nerve cells die and don't function, that part of the body is not able to control what it needs to, or is not able to function properly anymore. So we have millions of brain cells that can die every minute during a stroke. So one thing that we always like to say, at least I know in the field of neurology, is that time is brain. So it's very critical that we all understand the various symptoms of a stroke so that we can act fast and make sure that we get to the proper location, such as the emergency room, to get proper care. So knowing these symptoms can help save a life as well as reduce the risk of disabilities. The good news, though, is that up to 87% of strokes can actually be prevented. And research has shown that we can all take steps to prevent strokes by reducing and controlling our risk factors. So we'll go over all of those a little bit later in the talk this evening. So let's talk about the different types of strokes. So we have two different types of strokes. We have ischemic strokes as well as hemorrhagic strokes. Starting with the ischemic strokes, these are actually the most common types of strokes. So this is what we see most frequently. An ischemic stroke basically happens whenever an artery in the brain is blocked. So ischemia translates to lack of oxygen. So whenever an artery is blocked, that part of the brain is not able to get the oxygen that it needs, and thus it can't function properly. Now, underneath ischemic strokes, there are two main types of strokes. We have embolic strokes as well as thrombotic strokes. An embolic stroke is when you have a blood clot or plaque fragment that forms. And this is usually in the heart or the large arteries that lead up to the brain, such as our carotid arteries and our necks. And this clot or the plaque will move throughout the bloodstream to the brain. And then when it gets to a point, maybe at a turn of the artery or where the artery branches off, it can block it off, and this can lead to a stroke. We also have thrombotic strokes underneath ischemic strokes. And what happens with this one is you have a blood clot that forms inside of the artery that supplies the blood to the brain. So a lot of times this is, we can see this in, say, individuals who have poorly controlled high blood pressure, elevated cholesterol, poorly controlled diabetes, and all of those things can cause buildup of plaque on the on the inside of, or the walls of the arteries. And over time, this buildup can get to the point where it can actually block the artery, and then thus that can prevent oxygen getting to where it needs to, and then this can cause the stroke. Now, a less common cause of strokes are the hemorrhagic strokes. So a hemorrhagic stroke happens when a blood vessel in the brain actually bursts. Blood leaks out, and then this can injure and irritate the brain tissue. And it can also cause damage to other parts of the brain if that blood causes that part of the brain to push onto another part of the brain. So an ischemic stroke is an emergency, but a hemorrhagic stroke, we definitely need to jump quickly with this one as well. Now, the most common cause of a hemorrhagic stroke is usually often from high blood pressure. So if the blood pressure in those arteries can get so high, it can actually kind of cause the artery itself to burst. And again, this leads to blood that goes into the brain that can irritate the brain and cause things like weakness and also things like seizures, because blood is very irritating to the brain. And then at the last bullet, you see we have transient ischemic attacks. So a transient ischemic attack is sometimes, or a TIA, is sometimes called a mini stroke. I don't really like that term mini stroke because it's not actually a stroke. So the difference between a TIA and a stroke is that with a stroke, when we take a look at the brain, we can, on an MRI or additional imaging that we do, we can actually see permanent damage to the brain. But with a transient ischemic attack or a TIA, you can have stroke-like symptoms that go away, but there's not any permanent damage to the brain. So they don't usually cause, because they don't usually cause long-term damage, a lot of times people tend to ignore them and say, oh yes, I had this one time where I had trouble getting my words out, or one time where I couldn't move my arm, but it improved after 5 minutes, so I didn't worry about it. But this is still a serious warning sign of an actual stroke that could possibly happen. So I recommend never ignoring any signs of a stroke. Up to 40% of all people who experience a TIA may actually go on to have an actual stroke if they don't if they don't receive some sort of preventative treatment. So we really want to make sure that we understand the signs of a stroke. And at the time when you're having it, we don't know, or you don't know if it's going to be a TIA or a stroke, so they should all be treated the same. So we need to know how to react. There are a couple things that have been come up with to help us know how to recognize the various signs of a stroke. And in order to help with that, an acronym has come up called F.A.S.T. So you want to act fast, and each letter stands for a particular sign that you can see with a stroke. Now, I like this figure here. It can be found on strokeawareness.com, but it gives a lot of information about the various symptoms that can be seen and as they relate to this acronym, and then additional detail on additional signs that may be associated with these. Now, to start off with the B and B-FAST, B stands for balance. So if someone presents with like a loss of balance or dizziness, this can sometimes be an example of a stroke that happens in the back of the brain. These are less common symptoms we can see, but still could be related to a stroke. The back part of the brain controls, in most cases, a lot of our balance and coordination. So again, if someone has a sudden onset of difficulty with walking, if they're stumbling, not able to walk straight, or they're experiencing a lot of dizziness, whether it's lightheadedness or they feel like the room is spinning around them, this is an emergency. The next one, E, that stands for eyes, vision changes. So sometimes someone may notice like a sudden onset of blurry vision that doesn't go away, or most frequently, if the eyes are involved with the stroke, is actual loss of vision that again comes on suddenly. With the carotid arteries, so the arteries that come up your neck, these are the main arteries that supply the brain. The very first branch off of this artery is actually the ophthalmic artery, and that artery goes to your eyes. So if you have plaque buildup in your arteries in your neck, or if there's a piece of a plaque or a clot that comes from the heart, it can it'll reach that artery first. And it is a possibility that someone could have a stroke in their eye. We treat it the same way as how we would treat if someone has a stroke in their actual brain. Now, the F.A.S.T part, these are more common symptoms that we typically see with ischemic strokes. The F stands for face. So this includes facial drooping. So if one side of the face is not moving properly, say if someone smiles or if they're trying to eat and food is coming out one side of their face or their mouth, excuse me. And then another one is severe headache. Now, severe headache, we don't see that as frequently with an ischemic stroke, but this can be a sign of a hemorrhagic stroke. And sometimes we'll ask if someone comes in with a very bad headache, is this the worst headache that you've ever had in your life, or a thunderclap headache? And that can be a sign that there's blood on the brain from a hemorrhagic stroke. A stands for arms. So this includes weakness or numbness, and not only just arms, but as well as the legs. And oftentimes, as we'll discuss a little bit later, with the stroke, it'll happen on one side of the body. You can also have numbness or tingling in the face or the arms. If someone touches you or if you touch something, it might not feel the same. These are kind of symptoms that we can see with the stroke. S stands for speech. So if someone has trouble speaking, meaning that their speech is slurred, or they're having difficulty with word finding, or whenever they try to get their words out, it's like word salad. It doesn't make sense. And this oftentimes can come off as confusion. If someone is just kind of staring at you, they may not literally be able to get their words out, or they may not understand what you're saying. So there are different types of ways that our brain utilizes speech. And then T stands for time. So this is what I've already mentioned multiple times, but time is brain. So any of these symptoms, if there's any concern about a stroke, I highly urge you to call 911, or if you're close to a hospital, go to the hospital, or if you do call your family doctor, if you say any of these symptoms, they're going to recommend going to the hospital for further evaluation. So once at the hospital and the evaluation for strokes, there are a couple different tests and treatments. The number one treatment or test, that we have for a stroke is the neurologic exam. This is the best tool that we have when it comes to diagnosing a stroke. There's not necessarily a fast way that we're able to diagnose. So as neurologists and emergency room physicians have become very adept with understanding these signs of strokes and knowing, when things should be pushed a little bit further and when we should act aggressively. Now, one of the first things that's done when someone comes to the emergency room, I'm going to go ahead and go to the next slide, is a CAT scan. So a CAT scan is not necessarily used to determine if you've had a stroke or not. So say if someone has symptoms that just started maybe an hour ago and they make it to the emergency room, a CAT scan may not show the evidence of that stroke. It can oftentimes take up to 24 or 48 hours for a CAT scan to show that there has been a stroke there. But the significance of us getting a CAT scan immediately is to evaluate for blood. So we want to rule out if there has been a hemorrhagic stroke or not. The reason why this is so important is if someone is within a specific time frame, then we may be able to treat them for the stroke by giving a clot busting medication, which I'll go into a little bit more detail later. But again, a CAT scan is more so to evaluate and rule out blood, not to say yes or no, you have had a stroke. The next test that we look at, and this often happens after a patient has been admitted to the hospital, is an MRI. So basically, MRI is a large magnet, and there's a computer attached to it that takes pictures of your body. This is a longer test, so it can take sometimes up to 45 minutes. And because of that, we're not able to use it emergently in the emergency room. So again, it goes back to kind of relying more on our symptoms and ruling out further scary things like blood on the brain with the CAT scan. But the MRI is what we use to determine if there has been permanent damage to the brain within the first 24 to 48 hours after symptoms concerning for a stroke. Also, sometimes we'll look at the arteries that we have in the neck, so those carotid arteries that we've been talking about. And this is done with using a carotid ultrasound. So basically, it's just kind of an ultrasound where you're using sound waves to look at blood flow in the arteries in the neck. And the main thing we're looking for here is to look for if there's any blockage to those arteries where potentially a piece could have came off of the blockage and gone up to the brain. If we see a blockage in one of the arteries in the neck and we think that is the cause of the stroke, then that may be a part of our treatment in regards to maybe referring to a vascular surgeon to actually clear out the arteries in the neck. So with doing the carotid ultrasound, this is more so to kind of help guide our treatment going forward and hopefully prevent another stroke from happening. Another test that we do to look for the underlying cause of the stroke is an echocardiogram. So this is basically an ultrasound of the heart. So again, we're using those sound waves to take pictures of the heart. And what we're looking for here is we're looking to make sure that all the chambers of the heart are moving properly. We want to make sure that there's not any a clot that's sitting or resting in one of the chambers of the heart that could potentially have gone up to the brain. And we also want to make sure that there's not a hole in the heart where maybe a clot from the leg could have potentially gone up, gone through that hole in the heart and then gone up to the brain. So again, just another thing that we look at to help determine the cause of the stroke so that we know how to best treat it going forward. And then one additional test that we will sometimes do is get a different type of CAT scan where rather than looking at the brain per se, we're looking more at the arteries in the head and in the neck. Now, sometimes the clot may come up through the arteries in the neck, in the front part of your neck, but there are also arteries in the back of your neck that travel and control the areas in the back of the brain. So those areas that kind of more deal with balance and coordination. So though these are less common symptoms or signs that we see with a stroke, most often we don't see, it's not as common to see strokes in the back of the head with the balance and coordination that may be impaired. But if we see that, then we want to make sure that those arteries that control that part of the brain are nice and open and don't have a clot in there that we could potentially go and remove, or that we may need to treat with a different type of medication after discharge from the hospital. So like I said before, the neurologic exam is the best tool that we have for diagnosing a stroke. This is the quickest way that we have to diagnose, and we want to act quickly. And a lot of times in the emergency room, we'll ask questions like, when was your last known normal? Did you wake up with these symptoms, or did they happen in the middle of the day? And all of this matters because we do have different tools that we can use to treat an ischemic stroke by restoring their blood flow quickly. The way that we do this is with a medication that can be given through an IV. Sometimes I call this a clot busting medication. The formal name is IV TPA. So this is basically kind of a blood thinner that we can give through an IV if someone presents within 4.5 hours of the symptom onset, that can help to break up the clot and then hopefully help to reduce more permanent damage. Sometimes I've seen in many cases where we've been able to completely turn around a stroke where someone may come in and not be able to move one side of their body. And then after they get this medication, they can move that. But again, there are different time constraints that need to be considered with this. And this will all be something that would be discussed if the patient is considered to be a candidate in the emergency room. So now that we know some of the symptoms for a stroke, how we work up a stroke, what can we do to even prevent getting to that point? So who is most at risk for a stroke? Well, stroke can happen to anyone at any time. I know it's scary, but there are a few risk factors that an individual may have for a stroke. And some of these we're able to manage, and some of these we have no control over. So the risk factors that we cannot change, the main risk factor is age. So stroke can occur again at any age. Actually, 1 out of 5 people who have a stroke are under the age of 55. And most of this time, we're doing a lot of those extra tests that I was telling you about earlier to make sure that we're finding the underlying cause of that stroke, because we don't want it to happen again. And again, as we get older, that chance of stroke increases to where you can sometimes have a stroke and we never find out the cause of it. But definitely in someone under 55, we want to make sure that we figure it out. And I want to take that back. We want to make sure we figure it out in everyone. So let me repeat what I said with that. Now, another risk factor that can't be changed is gender. So more women have strokes than men. As we get older, so kind of age 60 and older, that kind of switches around a little bit where we tend to see more men presenting with a stroke. But an important and kind of scary stat is that more women die from strokes than from breast cancer every year. So it's really important that we, understand this and we recognize how serious these symptoms could be so that we can treat them. Race is another factor that can't be changed. So African Americans, Hispanics, and Asian or Pacific Islanders have a higher risk of strokes than people of other races, such as Caucasian. And family history. An individual may be at a greater risk of a stroke if they have a family member who's had a stroke in the past. And this more so actually kind of correlates with some of the risk factors that we can control. So coming to this next slide, heart disease. Now this oftentimes runs in families and we may not have as much control of it, but there are certain things like monitoring of high cholesterol, making sure that we don't have a high fat diet, making sure that if you have a history of high blood pressure or hypertension, that this is well controlled, that diabetes are well controlled. Smoking is a huge risk factor for a stroke. And I always recommend complete smoking cessation after someone has had a stroke. And if they're at a increased risk for having a stroke, if they have other conditions such as hypertension or diabetes, even more reason to stop smoking. Inactivity is also a risk factor for stroke that we can control. This can cause poor circulation in the extremities. So if you're not moving your legs, that circulation isn't going in your legs and you're at a higher risk for a clot that, if there's a hole in the heart, could potentially go up to the brain. And then that can also lead to obesity, which can affect cholesterol, blood pressure, diabetes. They're all intertwined here. And then atrial fibrillation. So this is kind of the second bullet there under high blood pressure. So this is a condition where your heart is not beating properly. So essentially what happens with this is your heart is beating irregularly. And when your heart is not pumping how it should pump, you can have blood that is resting in your heart, kind of at the base of like one of the chambers of your heart. Now, if you've ever cut yourself or if you cut yourself and you didn't notice and you just happen to look down, I'm sure that blood does not just continuously run down your arm or your leg. Resting blood or sitting blood clots off. So the same thing can happen in the heart. If that blood is not being pumped out of the heart properly, then it can start to clot off. And then if your heart gets one good pump, that clot there can then come out of the heart, go up into the brain and cause a stroke. So it's important that if someone has irregular heart rhythms, then they may need to be treated differently than someone who does not have an irregular heart rhythm. They may need to use a blood thinner to keep their blood nice and thin to prevent a clot from building up in the heart. Now, we've gone over kind of all of those things. So I just want to spend a little bit more time before we close out talking about in more detail some of the changes that we can see with a stroke, or basically some of the symptoms with a stroke. So the brain controls movement, feeling, communication, thoughts, and actions, a lot of different things. And any kind of injury to the brain, especially one from a stroke, can affect any of these abilities based on where the stroke was in the brain. Now, some changes are common no matter which side of the brain a stroke or any other kind of brain injury is on, but some other things are based on which side of the brain the stroke occurs on. Now, I do want to say that at the end of the day, this is more just kind of for your education. I don't think that time should be spent trying to figure out, oh, I think I'm having a stroke, or my loved one is having a stroke on the left side of the brain because they're having these symptoms. Leave that to your physician. And it's more kind of academic, and with kind of knowing that when we look at an MRI, I will know what part of the brain to look at for a stroke. Say if there's a very small stroke that might be missed if I didn't know the symptoms, knowing the symptoms, again, I know exactly where to look for to make sure that I'm not diagnosing someone with a TIA when they actually had a stroke. Now, the most common general effects from a stroke, you can have hemiparesis. So this means weakness on one side of the body, versus hemiplegia, which is when you have paralysis. So you can't move those extremities at all. Dysarthria, or slurred speech, is another common side effect from a stroke. Fatigue, as well as different kind of cognitive or emotional changes. Behavioral changes. Oftentimes, again, whenever we see behavior changes with the stroke, most of the time it may be because of an underlying aphasia or difficulty with speech. So someone may not understand what's being said to them, or they may not just be able to get their words out properly. And then, as we talked about as well, decreased field of vision. Now, with the left side of the brain, I want you to recall that the one side of the brain controls the opposite side of the body. So the left side of the brain controls the right side of the body. So if someone presents with weakness or paralysis on the right side of their body, I would expect to see something on the left side of their brain. The left side of the brain, most of the time, and most people control speech. So aphasia, or changes in the speech, is a common symptom that we can see in someone who has had a stroke on the left side of the brain. Also, behavior may just so happen to be a little bit more reserved and cautious than before if someone has had a stroke on the left side of the brain. Now, on the right side of the brain, of course, we can still see paralysis and weakness, but this would affect the left side of the body. A more interesting symptom that we can see with strokes that are on the right side of the brain is what we call neglect. So neglect is basically when you have a lack of awareness of what is happening on one side of the body. So neglect, examples of neglect could be if I were to hold up a picture and ask the person experiencing the symptoms to explain what they see on the picture. If they have one-sided neglect, they may explain the picture only on one side and completely ignore the other side. Or if I'm checking sensation, so I'm checking how they respond to me lightly touching their arm or to pinprick, so kind of a sharper sensation. They may not respond properly to telling me that I am touching both of their arms. They may say I'm only touching one arm, even though I'm touching both. So again, they're not paying attention to that other side. And this is oftentimes from a stroke that happens in a particular area of the brain on the right. Also, it may be harder for some patients to understand facial expressions or the tone of the voice. They may have more difficulty doing things like calculations. So right-sided strokes have a little bit more kind of unique symptoms than kind of the general symptoms that we tend to think of when we think of a stroke. And then emotional changes, these are also common after a stroke. Depression is a huge one. About 50% of people who have had a stroke may have some sort of depression. Now, the depression could just be from, frustration, anger, or sadness of what they're going through. But it can also be from the actual underlying changes in the brain and the changes in the chemical nature of the brain that is causing the depression. And, sometimes, and a lot of times, medication may be needed to help get out of this. It's really important to help manage depression because depression or not feeling like you want to do anything or just kind of being angry and wanting to avoid everything can also affect the recovery. And we'll speak a little bit more about that in one moment. Another symptom that we can see is pseudobulbar effect. So this is a phenomenon where you can have uncontrollable crying or crying, laughing, or other emotions. So basically you may cry or laugh at a time when you're not supposed to. So at a funeral, laughing at a funeral, or watching a funny movie, crying when it's clearly funny and there's nothing sad about it. So this is something that can be seen, and there are treatments for that as well. So improvement after a stroke does, excuse me, does occur spontaneously. So with a stroke, there's acute onset of symptoms. So acute, by acute, I mean a sudden onset of symptoms that come on quickly, and they may wax or wane, they may get a little bit worse, but for the most part, the main part of it is when there's that lack of oxygen or blood to that one part of the brain, you will get that sudden onset of symptoms. And then after that, the brain already is trying to recover. So how the brain improves, this relates to how things are happening beyond the stroke or beyond your stay in the hospital. So stroke rehabilitation programs, these start right at admission or whenever the patient is medically stable. The importance of this is they will help to improve the abilities as well as allow patients to learn new skills and coping techniques. So say if someone has their vision that's affected and their vision does not come back all the way. Occupational therapy or different types of therapy can allow their body to become more accustomed to this. So teaching someone to maybe when you're driving, rather than using or relying on your peripheral vision, you may have to turn your head all the way. Or with walking, you may have to use different techniques to walk or different techniques to eat or feed yourself, or even learning to use your left hand if you're right-handed and your right hand is affected. Depression is coming back a little bit to that. Depression after a stroke can interfere with rehab. So this is why it's really important for us to address this and to address it early if we see it. And then improvement often occurs most quickly within the first months after a stroke. I tend to tell my patients we tend to see the most improvement about 3 months following a stroke. So oftentimes, if I am noticing or I suspect that my patient is going to have a lot of residual symptoms or leftover symptoms after we have treated them for their stroke, I may push for more aggressive physical therapy at an inpatient unit versus doing something outpatient. And then I also make sure that I explain that we can't continue to see improvement for years after a stroke. Typically, I say kind of what we see about a year after a stroke. Those are kind of the changes that we're going to be left with. But continued therapy and continued motivation with working for improvement can allow someone to continue to learn new skills as well as different coping techniques. So that was a lot of information that I just threw out, and I definitely want to make sure that we have a lot of time to answer any questions or comments. I know that stroke is a very scary subject, and the main thing that I want to get out into the community and to all of my patients is understanding the signs of a stroke. And I don't want people to wait at home thinking that things will get better the next day. Act fast, because time is brain. Thank you.
Thank you, Dr. Nolan. We have just a few questions to start.
Okay.
The first, do you see stress being related to strokes?
That's a great question. I get that all the time. Direct stress, not as much, but that's not to say that stress cannot affect other things that can lead to a stroke. So it's maybe not be a direct cause of a stroke, but increased stress can cause elevated blood pressure. Stress can also be related to things like cholesterol, which can worsen plaque buildup on the arteries. So it's more of kind of has like a secondary relationship with the stroke.
Okay. The next question is, should a bystander assist a person having a stroke or just call 911?
I would recommend doing both. I would say call 911 first, and then if you say if someone is standing and they have fallen down to the ground, go and take a look and make sure that they're doing okay. If they've hit their head, of course, don't move them, but just make sure that they're in a safe place. But I definitely think that calling 911 should be priority.
All right, next we have, can stroke survivors fully recover?
Yes, I have seen many cases where a stroke survivor has fully recovered and does not have any symptoms. Now, we we can't always say that if someone presents with, say, a large stroke. So a large stroke that covers a lot of territory in the brain is what I mean by large. Because I've seen cases where someone has a quote unquote large stroke that covers almost one entire side of their brain, but then their recovery was phenomenal. But then there are also other kind of smaller strokes that are just kind of sometimes look like pencil points in the brain, and their debilitation following the stroke is significant. So a lot of times we kind of, when we think about a stroke, we think about debilitation and how is debilitating to a person. So if someone presents with a stroke where they lose control of their hand movement, so they have a clumsy hand, or they can't move their right arm and they're a right-handed person and they just happen to be an artist, this may have a greater impact on that individual's life versus someone who might be left-handed. So it kind of goes twofold with what people consider recovery from a stroke. But as far as for symptoms, it is definitely a possibility. Again, we see it more if someone gets to the hospital quicker. So as soon as they notice those symptoms, we have more techniques that we can do, given that IV TPA or that clot busting medication, or if we see an actual clot when we do the CAT scan looking at the arteries, we can actually send to the OR, where we can go in through the groin and go all the way up to the brain and actually pull that clot out. So there's more treatment options if someone gets in quickly.
All right, the next question is, what is the most common symptom you see in people who have had strokes?
So the most common symptom that I see is between weakness in the face, numbness and tingling on one side of the body, or weakness in the arms and the legs. Now, they're depending on where in the brain. Sometimes we can see where just the arms are involved or just the legs are involved. But the more common kind of artery that we see that's affected in a stroke will oftentimes affect the arm and the leg, as well as maybe some numbness or tingling. So those are the more common signs. Also, like I said before, the left side of the brain tends to control speech. So if the stroke just so happens to be on the left side, we'll commonly see someone present with changes in their speech. More often an expressive aphasia. This is type of speech change where someone has difficulty with word finding, so they may not be able to get their words out properly.
All right, this may be the last question. Are stroke survivors at a higher risk of having additional health problems?
So it depends on the severity of their symptoms or their residual symptoms. So if someone has a stroke that, significantly affects their ability to walk, or affects their ability to swallow, this can put them at a higher risk for having more difficulty with eating, maybe even having to have a feeding tube. So it really just depends on kind of where the stroke has impacted and the symptoms that someone has. But not all stroke survivors are at increased risk of other comorbidities. I hope that answered that question.
I believe it did. We don't have any more questions coming through. That was a wonderful presentation. And if no one else has any more questions, we can wrap everything up. I'll give just a minute or so for additional questions to come through.
Okay. Those were all really great questions. I feel like those were all kind of the most common questions that I get whenever I work outpatient, meaning I'm not in the hospital. So I'm not seeing patients in the hospital anymore, but I get them kind of maybe, a week or two after they've been discharged from the hospital after a stroke, and coming with family and the patient. The most common questions are, okay, well, where was my stroke? I always like to show the MRIs, and why did I have a stroke? So I make sure I review all the things that were done in the hospital. And if I feel like a test was missing, I'll order a test just to make sure that we've crossed all our T's and dotted all of our I's. And then prognosis is a huge thing. Kind of what can I expect going forward? So those are the questions that you guys have asked are all great things to know or to ask to your provider when going for more information.
Oh, we have one more question. What should caregivers of elderly parents watch for?
In regards to, hi, Rhonda, in regards to watch out for to rule out a stroke, or watch out for if they've already had a stroke? Things to look out for, I'll say, if to evaluate if you're concerned. Okay, yes, to see if they've had a stroke. The same symptoms that we spoke about before. So, looking for, say, if you have an elderly parent who uses a walker already, then kind of evaluating, kind of watching the way that they're walking and seeing if there's any change in their gait, or if they, complain about, oh, I can't lift this leg up. Sometimes it may have been going on for a while and they may not have said anything, but if they mention it, kind of monitor it closely. And if there is concern that, okay, yes, this is something new, either getting in with their family doctor, or if it's happened within, the past week or so, going to the emergency room. Other things to look out for would be any kind of changes in behavior. So not eating like they were eating before, or increased confusion, or just confusion, period. Those are all things that I would say would be an emergency, because it could be a stroke, or, it could be something as simple as, well, not simple, but could be something like a urinary tract infection, but still, warrants evaluation. Now, things to look out for or watch for after a stroke. I think that is more so the biggest thing that I see in elderly patients who have had a stroke. I see it in young, those kind of in their 30s and 40s who have had a stroke, but then also kind of I see jumps of it in the elderly, where we see increased depression. So I would monitor for things like that, and making sure that, again, they're eating properly and that they seem to be motivated to work with the physical therapy. I know a lot of times it may be difficult to do outpatient therapy, but I highly recommend, if there's any way at all possible, I recommend outpatient therapy over at-home therapy, even in our elderly patients, just because it's a lot better. There's more equipment, and I feel I've seen that recovery is quicker when it's done on an outpatient basis versus inpatient.
Dr. Nolan, do you see a lot of younger people having strokes?
I see more than I would like.
Yeah.
I do. I won't say that I see a lot. It still is a shock if I see someone like in their 30s, even their 40s, who has had a stroke. Definitely starting to see it a little bit more in the 40s, but in 20s and 30s, it's always a shock. And in most cases, there may be an underlying cause, like what we call a PFO, or patent foramen ovale, basically a hole in the heart. So if there's any kind of clot that builds up in the heart, or if a clot comes from the legs or anything, it can go through that hole in the heart and go to the brain. That's a common underlying factor that we see in young individuals who have had a stroke. Also clotting disorders. So any kind of disorder that makes their blood more sticky, or more likely to form a clot. So there's different blood work and things that we may perform in a 20 or 30-year-old that I may not consider initially in, say, a 60-year-old.
Looks like that's all the questions we have tonight.
Okay.
Thank you for such a good presentation and good information. And thank you everyone for joining us and Dr. Nolan tonight. Please continue to check out our classes that we have listed on tanner.org.
Yes, please do that. And thank you all so much again for logging on tonight and taking the time to listen to me ramble on. And I like I said, I work in Villa Rica. So if there are any questions, I don't mind anyone reaching out to me. You can, I don't mind sharing my email address. Is I'll write it actually in the box down here. If anyone wants to email me any questions, or you have everything. So it's jnolan@tanner.org. There you go. So please don't hesitate to reach out. Any other neurologic questions? I'm new to Tanner, and I am working on, just again, trying to make sure that the community knows that we're here. Tanner finally has neurology, and we want the community to know that, and know that we're here for any questions or concerns that anyone has. So thanks again.
Thank
You all
so
are very
much.
welcome.
All right, everyone have a great evening.
Good night.
Bye.